live in 5, 4, 3, 2, 1. We are live now.
Good afternoon, everyone. A warm welcome from Asia Pacific Spine Society in this third webinar among the series of 4 on scoliosis and spine deformity, the APSS MEDTRONIC webinar program. The third one is live today. And we have a host of faculty members, distinguished faculty from across the Asia Pacific board. With all the faculty members here, I will take this opportunity to welcome all of you for joining and chipping in the webinar on this August day of 28, 2022. May I now request the President of Asia Pacific Spine Society, Dr. S. Rajashekharan sir, to please take over and give the welcome address.
Thank you, Vishal. Good morning, good afternoon, and good evening to all of you from wherever and whichever place you are in this world. I would like to welcome all of you for this third in the series of the Asia Pacific Spine Society's online webinars. This has been one of the most successful initiatives of APSS for this year. And the previous 2 webinars, the first and second in the series of the adolescent idiopathic scoliosis, were huge success. And I was particularly elated to know that although there were online registrations crossing 300, but actually there has been more than thousands of views after that in the OrthoTV. And this has been reached by delegates from almost more than 35 countries. So this has become a singularly important event for APSS. And I would like to congratulate the entire education committee and the online education committee in particular, and Vishal, its chairman in particular, for this, planning it out all so well, getting the best of the faculties, making the program very crisp and interesting, and attracting the attention of spine surgeons across the countries. This webinar is the third in the series, and this is on early onset congenital and neuromuscular scoliosis, a problematic field which stumps us from time to time. And I'm sure that the excellent faculty that he has gathered from Singapore, Malaysia, Japan, China, and Hong Kong. And I'm sure that there is going to be an excellent discussion around. So I very much look forward to this, and I hand it over back to Vishal, welcoming all of you again for this educational event. Thank you, Vishal.
Thank you, Dr. Rajashekharan sir, for a warm welcome to all the faculty and delegates around here. So this webinar, APSS MEDTRONIC webinar program, has an educational support from MEDTRONIC, and we go hand in hand to spread across the world for these webinar programs in future. And we look forward to many such collaborative events on academic front with the industry in future as well. We all know that early onset scoliosis, congenital scoliosis, and neuromuscular scoliosis poses challenges which have been an enigma and continue doing so even today. We have a host star faculty member in a host line from various parts of the world. We have Dr. Zhang from China, who's going to be delivering his deliberation on early onset scoliosis on natural history and challenges. Dr. Kota Watanabe from Japan is then going to help us understand the various principles, techniques with casting and bracing in early onset scoliosis. To move on and hand over the baton to Dr. Ken Chong from Hong Kong, who will be helping us understand in detail about the magnetic rods and growth rod selection of patients and long-term results. We're going to be having Prof. Kwan on treatment options in congenital scoliosis and Hemi Vertebra management. Dr. Rajashekharan himself is going to help us understand the nuances of severe rigid scoliosis and the role of halopelvic traction with intraoperative releases in these patients. Neuromuscular scoliosis, Dr. Yang from Hong Kong is going to help us understand the details, and the principles laid down by all these speakers are going to be discussed with practical tips by our case presenters, Dr. Chris Chan, Dr. Dheeraj Sonavne, and Dr. Lau Lok from Singapore. We look forward to this academic meeting, and I hope that we are going to have a fruitful discussion in the coming 120 minutes. Today, to run the session with me, I have 2 moderators who are going to help us run the flow of the academic meeting, Dr. Chiked and Dr. Vijay Loya. Over to you guys to run the session, please.
Thank you, Dr. Vishal. So without any delay, I think we will start with the first speaker, Dr. Zhang.
Yeah, thank you very much for your invitation. Let's share my. So today's topic, I will focus on the congenital early onset scoliosis, about its natural history and also the challenge of the treatment. So now we still use the Winter's classification. Usually it's classified into three major types: filial formation, filial segmentation, and mixed time. And the Hemi Vertebra and the mixed time is the most common type. This is McMaster's classification about Hemi Vertebra. It usually defined into two categories. One is fully segmented, the other is partially segmented, and also further divided by the deformity into incarcerated and also non-incarcerated. So this is a history of the fully segmented non-incarcerated Hemi Vertebra. Usually, the curve will progress 1 to 5 degrees, but for some lower thoracic or thoracolumbar Hemi Vertebra, usually can reach a severe degree before 5 years old. So this is a 5-year-old female. So this is 2 years old. You can find this far lateral T11 Hemi Vertebra. We just keep her and observation 3 years. This shows no progress. This another case, 2-year-old. You can find there is a couple of Hemi Vertebra and also butterfly vertebra. Since that this Hemi Vertebra is far lateral, so we still keep her and observation. This 5-year-old, 10-year-old. You can see there is a little progression of the curvature. Another 4-year-old girl, you can see there is a partially segmented Hemi Vertebra with mild kyphosis. So 2 years follow-up, so there is a mild progression. So this another Hemi Vertebra, the thoracolumbar, is L1 far lateral Hemi Vertebra. And we think the progression should be slow, so we just keep her under observation 2 years and 8 years, 6 years follow-up. So not every Hemi Vertebra need to be resected, but for the fully segmented non-incarcerated Hemi Vertebra, the usually is the progress and need early surgical intervention. For example, this female 5-year-old with no treatment at 19 years old, you can say they're quite severe kyphosis scoliosis with overweight rotation. This is a 30-year-old image had severe kyphosis. So for this kind of Hemi Vertebra, fully segmented non-incarcerated should be treated earlier. So this example, this 5-year-old female, you can see there's empty Hemi Vertebra fully segmented with lumbar kyphosis. This type which need early surgical treatment, but he also has a thoracic Hemi Vertebra, but it's not segmented. We just do a Hemi Vertebra resection, short fusion, and leave the upper thoracic and observation. There is that 3 years follow-up. You can see there's no progression. So we treat the Hemi Vertebra according to his type to decide our treatment. So there's 4 years follow-up. This another example is a 2-year-old male is a bilateral Hemi Vertebra. So during the follow-up, there is no progression. But this surgeon chose to do a surgery, but after surgery, 2 years of surgery, the deformity developed to a very severe degree. This is 4 years post first operation. Why there is a progression? Because he removed all the posterior elements. That's why he developed quite severe kyphosis. We have to do a posterior revision. All these examples shows only the fully segmented non-incarcerated Hemi Vertebra need early surgery, but the other type just need observation. There is much challenge in treatment of congenital early onset scoliosis because we have to control the deformity and also try to preserve the growth, especially for large creeping curvature. For this 3-year-old female with 83 degree of scoliosis and kyphosis. So some surgeons suggest the cause for the congenital. However, according to the literature, the cause for the congenital early onset scoliosis only can control the progression. There is a very mild correction. This is another report, same result, very mild correction, but the cause need repeated anesthesia, maybe have some mild side effect on the brain growth, and also the cause has too much complication, including the skin irritation and also some friction-induced ulcers. So the cause for congenital scoliosis is still remain controversial, but they can try. Actually, they can buy some time. However, it may defer the growth of the thoracic and the line. So we reported dual green rod in the congenital scoliosis, but till now we found with the increase of the number and the longer follow-up, the complication rate is very high, about 76%, quite similar to the result of the literature report. This 3-year-old female, quite severe kyphoid scoliosis. So we chose the green rod, but he developed rod detachment and the rod breakage and the proximal PJK. 8 years have nice surgery. We have a good result. However, this girl underwent too many surgery. Why there is a so high incidence of the complication? We think the dual green rod can control the apex and leave too much press on the screws and the pedicle. This reason. And also, if we just put upper and lower screw, we have very bad control of the apex and can't improve the thoracic cage. Some Turkey teams try to do the Convex instrumentated Hemi Epiphyseal disease. However, since they use the single rod, there is still very high incidence of the complications. So the Scylla technique is another kind of apical control. So we can correct the major curve while leaving the other curve to grow freely. So in our hospital, we have two apical control techniques. One is the apical convex control screw. This is indicated for some flexible long congenital curve. The other technique we describe is a hybrid technique. We can do a osteotomy, short fusion, and together with dual green rod. For some flexible curvatures, we can use the apical control screw. This is a girl, filium segmentation, and also that myelin. So we just use the 2 incision and insert control screw at the T10 and connect with the dual green rod. So this is our surgery. You can see we have a good correction result. This is another case, 3-year-old congenital. This is a 5 years follow-up. We use the T11 apical control screw. This is another case, 53 degree scoliosis and T10 apical control screw. We can have very good content. 6-year follow-up shows quite good correction. Although he has a spontaneous fusion, I think this is a good thing, which means we don't need final fusion. Another technique is a hybrid. We usually indicated to a severe and rigid angular kyphosis. We reported it in 2013 in Vancouver. This is a case, 5-year-old male, 88 degree scoliosis, big mass on the apical area. So we do a T11, T12 vertebral column resection, short fusion, and using green rod to control the thoracic deformity. This is 4 years follow-up. showed good correction of the deformity and also the thoracic cage. This is 8 years follow-up. This showed quite correction result. This is another case, 9-year-old female. We do a T11 PVCR and use a green rod. So this 5 years follow-up shows good correction and also have a spontaneous fusion. Another case, 3-year-old girl had very severe scoliosis, multi-level deformity, quite rigid. We do a T8 PVCR short fusion and green rod to control the proximal and the distal curvature. This is 1 year post-surgery. This 3 years follow-up showed good correction results. And also the volume of the thorax was improved also. Another case similar, we do a T8 PVCR short fusion and green rod. This is a follow-up. So we compared these two groups, hybrid and traditional green rod. It truly can have bigger correction in the hybrid group, and also there's no bad effect about the T1 to T12 length, which means short fusion didn't affect the growth of the T1 to T2. And also it really decreases the incidence of the complication. But maybe you have the potential neurological complication. So take-home message, I think, for the congenital early onset scoliosis, the observation is a good method for this deformity. Only the fully segmented, non-incarcerated Hemi Vertebra need early surgical intervention. But for long creeping congenital early onset scoliosis, the cost treatment still remain controversial, and green rod with apical control technique can give good result. Thank you very much.
I would like to thank Dr. Terry Zhang for his talk. And now I would like to invite Dr. Kota Watanabe to give his talk on casting versus bracing in EOS management.
In the beginning, I have to say that my assigned title was Casting versus Bracing in EOS Management, but I changed it to Casting and Bracing in EOS Management. So this is a representative case showing the downside of the early correction and fusion surgery for EOS patient. At the age of 2, she underwent posterior fusion, and at the age of 8, she underwent anterior and posterior fusion. At the age of 38, she required chronic oxygen therapy, 1 liter during the day and 2 liters at night. So why correction and fusion surgery is not adequate in EOS? Because it disturbs longitudinal growth of the spine. It disturbs the growth of the thoracic cage, and finally, it resulted in respiratory problem. As all you know, treatment of EOS consisted of conservative treatment and surgery. As a conservative treatment, bracing and casting has been used to control the spinal deformity. In 2005, Mater reported a case series of 136 infantile scoliosis, aged less than 4 years, who were treated by serial corrective plaster jacket. In 94 children, mean age of 1 year and 7 months, with a mean curve angle of 32 degrees, the scoliosis resolved by a mean age of 3 years and 6 months. This slide shows the regimen of casting. The indication for casting is curve angle of more than 25 degrees with a progression of more than 10 degrees. The intervals of cast changes are for patient less than 2 years, it is 2 months. For patient more than 2 years, it is 3 to 4 months. The rationale of casting or cast provides a non-removable and well-molded jacket. It can apply a consistent corrective force on young spine with external force of cast during rapid spinal growth. The spine will continue to grow in corrected position and the final shape can be altered. Thus, there are two purposes of bracing and casting. First is definitive treatment, and the second is by means of to delay surgical procedure. Casting has been used for EOS patients as a definitive treatment. Meta reported that there are 94 patients out of 136 patients, the scoliosis resolved by mean age of 3 years and 6 months. Good source reported that there are 36 patients out of 41 in idiopathic scoliosis group and 22 out of 33 patients in non-idiopathic group did not need a growing loss surgery. Sanders reported that there are 49 patients out of 55 did not need growing loss surgery. So they reported that there are factors for successful cast treatment. First, treatment begins before the age of 2 years. Second, idiopathic curves. Third, curve angle less than 60 degrees. Casting has been also used as a means to delay surgical intervention. Feature reported that the surgical intervention was delayed in 15 out of 29 patients by 39 months. Waldron reported that the surgical intervention was delayed for an average of 17 months. So why the surgery need to be delayed? Because the surgery has higher complication rate. For example, growing loss system report to have a complication rate of around 50%. The Kaplan-Meier analysis of the complication indicated a patient who had 6 procedures of rod lengthening had a 50% chance of experiencing a complication. Thus, the number of lengthenings should be minimized, and the start of growth-friendly surgery should be delayed to decrease complication. There are some clinical questions. One of them is that does casting works for congenital scoliosis? Demir Kion reported that there are 11 patients with progressive congenital scoliosis treated with serial casting. Average time in casting was 26 months. The curve magnitude decreased from 71 degree to 55 degree at the latest follow-up. During the treatment period, none of the patients required surgery for curve progression. Thus, they conclude that the serial casting is an effective time-buying strategy to delay surgical interventions in congenital scoliosis. So I need to comment on the bracing. The laws of bracings are, unfortunately, there are not sufficient evidence to support the bracing as a sole treatment method for EOS. It is reported that the bracing is effective only for patients with significantly smaller rib vertebral angle differences and curve angles. Thus, the bracing is used as an adjunct to the cast treatment. Use after satisfactory correction is achieved with casting. Use during cast holidays when patients are left cast-free from a few months. The most common problem of casting is minor skin complication. The other problem is impairment of ventilation. Since a rigid and molded cast compress the chest wall, it is reported that after the application of the cast in EOS, peak inspiratory pressure was 32% higher than the baseline volume. The potential problem of casting is repeated general anesthesia. In 2016, FDA warned that the repeated use of general anesthetic and sedation drug during surgery or procedure in young children younger than 3 years may affect the development of children's brain. Thus, I think the solutions are reduce casting and increase bracing. Try casting without general anesthesia. So this is a regimen of casting in your institute. The indication of bracing is scoliosis more than 25 degrees, and the indication of casting is scoliosis of more than 30 to 45 degrees. We apply the cast for 1 month and remove it, and the bracing for 4 to 8 months. The duration of bracing will be determined by the evaluation of the effect and the compliance of bracing. So Dr. Kawakami reported that the cast applying with a general anesthesia. The key points are: we ask the parents to stay beside the patient, holding the patient's hand to make them feel relaxed. Before starting applying cast, we ask the patient to choose their favorite anime that they like to watch during casting. Putting a neck curl of the patient instead of a halter strap for traction. Because children do not like wearing a halter strap and traction, because it lobs into the skin during traction. So this is summary of my talk. Casting and bracing is an effective treatment for EOS. It may be effective for most idiopathic curves or are meant to delay surgical intervention in more severe idiopathic, syndromic, and even congenital curves. Since repeated general anesthesia may affect the development of children's brain, casting without general anesthesia or reducing the cast changes should be considered. Thank you.
Okay, thank you, Professor Kota Watanabe. Yeah, so we changed
There's a question in the chat box.
Yeah, so we'll go for questions. Yeah, all right.
Yeah, Dr. Sudhir Srivastava sir wants to ask how one should manage a case of congenital cervico-dorsal junction scoliosis in a 3-year-old child. The question is open to the previous speakers, Dr. Zhang and Dr. Watanabe.
Did you have any answer? Should I?
Should I manage a case of continuous?
If we try to control by casting, we usually apply. I usually apply the Milwaukee brace, but I don't think it's effective or not. But I will try first. But I think that even for the surgical intervention, the region at the cervical dorsal junction, cervical thoracic area is, I think, it's very difficult. Terry, do you have any comment for that?
Professor Zhang, maybe you want to comment something?
Sorry, I didn't hear the question. Where was the question?
Okay, the question is how one should manage a case of congenital cervical dorsal junction scoliosis. Congenital cervical dorsal junction scoliosis in 3 years old child. 3 years old. Yeah.
Okay. So that this depends on the classification. Just as I mentioned earlier, if the hemi vertebrae is a big one and it also is a fully segmented and non-incarcerated hemi vertebra, I think the usually is progressive. I don't think cast or brace can do. So for this case, I would operate, do the hemi vertebral resection, try to get part of correction of the curvature.
Yeah, maybe I have one question to Professor Zhang. If you mentioned that we have to monitor the progress of the lesion. How is your regime of monitoring? I mean, in terms of how often? Does it depend on age, or does it depend on what other factors? Yeah.
Yeah. If the child is younger than 5, and also I noticed there is a congenital deformity, I will follow up this patient at the first year. I will follow them every 6 months, and if the progression is very mild, I will follow them at 1 year period. So usually, if this is older than 5 years old, I usually follow them at a 1 year period.
Thank you. Maybe I will proceed with one question with Professor Kota Watanabe. If you have a patient you started treatment on brace, but the curve still progressed, so when would you decide to abandon the brace or to rebrace or recast? If you have a patient in cast or brace that have progression, when do you decide to recast or to convert to surgery? What are your factors that make your decision?
So I think I usually wait for example, if it's neuromuscular or idiopathic curve, I think if it congenital, it's very different. But if it's idiopathic or neurovascular, I will wait until the curve angle increase to 70 degree or 60 degree around that, and then I will prepare for the surgery. And usually at that time, the curve angle will be 70 to 80 degree. But if it's neuromuscular or idiopathic, I can correct it with growing rod below 30 degree or 40 degree by the growing rod application. So that's my strategy.
All right, thank you very much. So I think we will proceed with the next speaker. Thank you very much for the great talks. The next speaker will be Professor Ken Chong. Yeah.
Spine Society for their invitation for me to give this talk. I would like to first of all acknowledge Dr. Jason Chung, who has helped me throughout the years with this procedure, as well as the preparation of some of these slides. Now, I guess we get to talk about this topic because we were the first center in the world to perform a human clinical trial using the magnetically controlled growing rod. And in fact,
I'm not seeing the video here. Can you please play again? Our apologies for some technical errors. Yeah, I think they should be working it out.
I would like to thank the Asia Pacific Spine Society for their invitation for me to give.
I think it's the same problem. No video. Should we proceed with Prof. Kwan's lecture, then Prof. Ken Chung's lecture after Prof. Kwan? Maybe you got time to sort it out. Is it okay? Sorry about it. Okay,
I would like to thank the Asia Pacific Spine
so
Society for their invitation for me to give this talk. I would like to first of all acknowledge Dr. Jason Chung, who has helped me throughout the years with this procedure, as well as the preparation of some of these slides. Now, I guess we get to talk about this topic because we were the first center in the world to perform a human clinical trial using the magnetically controlled growing rod. And in fact, we published this case report on the first patient in the world that received this rod. She had this procedure some 12, 13 years ago now. And since that time, she's grown from a young girl into a promising young lady, and indeed recently represented Hong Kong in the Para Games and got a medal in table tennis. Now, we've also subsequently published our longer-term results on this procedure, and I believe this report to date is still one of the longest follow-up reports on clinical outcomes. And to cut a long story short, the rod works. What we were able to show was that the spine continues to grow over the years, and that we are able to correct and maintain correction over time, although that can of course occur. We also demonstrated techniques of reducing radiation exposure by using ultrasound to monitor distractions as opposed to repeated X-rays, and shown in this study that there is good correlation between ultrasound measurements and X-ray measurements, as you can see here. Now, so if you want to start doing this procedure, what are the best and indeed the worst indications? I think we can divide this into patient factors, disease factors, surgeon factors, and then now at the very end describe to you what I would consider to be an ideal case. So let's look at patient factors first of all. I think age is one important consideration. Ideally, you don't want it to do it too young or too old. Too young because then they would need multiple rod changes. In general, you can consider, you can think about that for every 2 years, you would need to change to a new rod because you would distract. If the distraction is successful, you would run out of rods to distract after about 2 years. So to me, 6 to 8 years old, maybe even close to 8 years old is better because that means perhaps one change of rod before you can go on to a final fusion, limiting the number of procedures. Also, it's easier to perform this procedure in a slightly bigger child. Although having said that, bigger child is good, but too big doesn't work. And indeed, too small a child is also difficult. One important consideration is that this rod has a rigid portion housing where the magnetic motor is. And this portion is not bendable. So you need a minimum clearance of this much. And that is before you can actually implant the rod. Now, there are two sizes to this particular rod design. There's a 90 millimeter housing, which is the longer, so-called the standard rods. And then they have the smaller size ones, which has a 70 millimeter housing, which is slightly smaller. But of course, with a smaller housing, the rod also does not distract so much. So keep that in mind. And you really need some clearance on either side of this housing or actuator so that you can actually implant the screws. Now, on the other hand, if the child is too big, the rod can only exert a finite amount of force, so it may not distract, if the child is too big and too heavy. So this is an example of a case in which we really, one of our cases in which we really only got minimum clearance, and it didn't work very well because we had to force the rod down. There's a lot of stress on the anchors, and the chance of failure and so on is much higher. So you can see what I mean by needing a degree of clearance before you can fit the anchors in. And this is another child that we learned from experience, rather obese, as you can see, and one, because of the weight, and two, because of the skin thickness, it was actually very difficult to distract this rod after implantation, and that was a failure. Social circumstances are important because the child will need to come back for distraction, so you need to consider whether they're willing to travel back, as well as the frequency of distraction, and we'll talk a little bit more about that later. Our practice is to distract monthly because it seems to make sense to me in that this is a growing rod, so we want to mimic growth. At the same time, we want to minimize inconvenience. So for us in Hong Kong, we will do it on a monthly basis. Also, the other aspect is that the child will need to be calm and be able to keep still for the distraction episodes. Now, disease factors. There are many different types of conditions leading to spinal deformities that could be amenable to this procedure. To me, the best are probably idiopathic and syndromic because these are the ones with the flexible curves, and the patients may be ligamentously lax, and so they are easy to distract. That's not to say that you cannot do it for other procedures, but you need to consider the pros and cons carefully in those situations, and they may not be ideal cases. So let me give you an example. This is a 5-year-old child with Marfanoid features. See a high Baton score, ligamentously lax. Of course, always we will initially treat with brace first, and then subsequently over a couple of years there is in-brace deterioration, and therefore we decided to go on to carry out a magnetically controlled growing rod procedure as shown here. Good initial correction, and you can see as we distract the rods, a clear area develops in the middle as the rod distracts, and that can actually be measured so that we actually know how much distraction has occurred. And over the time, you can see how this portion lengthens nicely. Correction is maintained over time, although subsequently you can see this portion even getting longer. That's what I mean when I say you run out of rods, because after about 2 years you would run out of rod. The rod has an overall distraction length of 48 millimeters. So that's what I would consider my ideal case, if a 5, 6 to 8 years old, slim build, flexible, cooperative, with a moderately progressive curve. Now, in terms of timing of distractions, should we do it monthly, 3 monthly, or 6 monthly? This practice varies around the world. There's really no scientific evidence. We are in the middle of doing a randomized controlled trial, looking at short versus long distraction frequency and the effect on outcome, as well as quality of life, etc. My own personal experience is that I think it's very difficult to distract beyond 4, maximum 6 millimeter in one go before the rod fails to distract or it starts clunking. So I would prefer not to leave distraction episodes to be too long. Otherwise, you're not going to get enough height gain or that is equivalent to their annual growth, if you like. Although having said all that, there are complications. There are related both to growing rods, as shown on this side, and also related specifically to this implant design. And it's not the subject of the current talk because of time limitation, but bear in mind that there are multiple complications, and because of these complications, you cannot guarantee that this is the one and only procedure that the child will have. And indeed, in this study, we demonstrated that after initial implantation and before the change of rod, due to running out of length of distraction, there is a 46 or almost a 50% chance, if you like, that over 2 years the child may need another operation due to a complication related to either the rod itself or the procedure. Nevertheless, though, having said all that, I do feel that this procedure is a breakthrough in early onset scoliosis management. The non-invasive outpatient lengthening is a real bonus for the child. I mean, now when we see a child coming into clinic, they're happy. They don't think of us as an enemy because every time we see them, we want them to have a GA and an open distraction, etc. And the results, I think, are comparable to a traditional growing rod, except that you don't need so many procedures in between. There are still many questions that needs to be answered, and I won't read them out one by one. And I think perhaps these are some of the future directions for research that we should continue to pursue. With this, I'd like to thank you for your attention.
I would like to thank Professor Chong for his talk, and now I would like to invite Dr. Moon Kwan for his talk on treatment options in congenital scoliosis. Floor is yours, sir.
Yeah, thank you very much for the invitation. Can you play the video? Treatment options in congenital scoliosis. No disclosure. Congenital scoliosis is a progressive three-dimensional deformity of the spine due to the congenital vertebral anomalies. This condition is due to the developmental defect during the first 6 weeks of gestation. 30 to 60% have abnormalities occurring at other sites. The most common are neuro, cardiac, and genitourinary system. Classification. The classification is mainly based on the radiographic appearance of the malformation. There are 3 groups. Failure of segmentation, example, unilateral bar and block vertebra. Failure of formation, example, Hemi Vertebra or wedge vertebra. And lastly, a complex abnormality. Most commonly, the congenital lesion is classified using the original description by Winter. Recently, a new 3D classification was introduced by Kawakami, which allowed a better surgical planning. Treatment options. The principle of treatment for this condition is early diagnosis and early aggressive surgical intervention to treat and prevent the development of the severe deformities. Therefore, the hallmark of treatment is early diagnosis and recognition of deformity that will progress. In general, 25% of curves are non-progressive, 25% mildly progressive, and 50% highly progressive and will require treatment. McMaster and Osuka reported 3 groups of patients as shown in this table. The group outlined in red is highly progressive and therefore recommended for early intervention. Treatment option. Observation is for non-progressive curve with balanced spine. Treatment option bracing. Bracing is rarely indicated. It's a time-buying strategy. It may be indicated only for long flexible curve or to control the compensatory curve. Surgical treatments. The aim of surgical treatments are to arrest the progression of the curve and to maximize the correction of deformity. The following are the factors that affecting the surgical decision: the congenital abnormalities itself, the age of presentation, structurality of the adjacent compensatory curve. These are the surgical treatment options available for congenital scoliosis. Option 1. In-Situ Fusion. This is a prophylactic fusion strategy aimed to halt the progressive asymmetrical growth. The ideal indications are congenital failure of segmentation with significant remaining growth with minimal deformity. However, the problem with in-situ fusion are it requires anterior procedure and posterior only fusion is known to lead to crankshaft phenomenon. Option 2. Partial fusion, convex Hemi Epiphyseal disease. This procedure requires removal of lateral half of the disc and to fuse the convex vertebrae to arrest the growth. The ideal indications for this procedure are congenital failure of formation with significant remaining growth, single level, less than 50 degrees. A case illustration: a 4-year-old female diagnosed to have Hemi Vertebra L2. The curve progressed from 37 to 47 degrees at 3 years old, 50 degrees at 4 years old. This procedure was performed. Successful convex fusion was achieved. Curve maintained with good coronal balance at 2, 6, and 12 years follow-up. Option 3. Hemi Vitrectomy. This procedure is the most widely used technique. It provides immediate deformity correction. The ideal indications are congenital failure of formation with single level more than 40 degrees. Yazil reported a multicenter retrospective study of 76 cases and concluded this procedure produces better deformity correction compared to Hemi Epiphyseal disease, in-situ fusion, instrumental fusion without a resection. However, this procedure has an increased risk of complications. With regards to posterior only versus combined anterior-posterior approach, Barrett and Carrick reported that posterior only surgery has the same correction rate but a lower operative time and blood loss. A case illustration: a 9-year-old female diagnosed with Hemi L1 and L3. Hemi vertebral resection was performed. Intraoperative view after screw insertion. This was the Hemi L1 location. In this case, after laminectomy, the osteotome was inserted into this space to disengage the Hemi vertebra. Once the Hemi was removed, discectomy was performed. Bone graft was inserted. The gap was compressed under neuromonitoring guidance. The correction was from 71 degrees to 34 degrees, and the curve maintained at 3 and 6 years follow-up. Option 4. Distraction realignment. The congenital anomaly may lead to severe deformity, especially if neglected. The goals of this procedure are to avoid fusion in immature spine, to provide gradual correction, to permit spinal and pulmonary growth. The ideal indications are a complex congenital deformity, neglected type, involve a long segment of spine in immature patient. So a case illustration: 8 years old with Hemi T12 and L3. Presented at 5 years old and was neglected. Curve worsened from 64 to 101 degrees at 8 years old. Dual growing rods was performed. The curve was corrected further to 46 degrees at 6 years post-op follow-up. The use of dual growing rod in congenital scoliosis were reported in the literature with reasonable good result. However, the growing rods are inappropriate in curve, there is lack of stable ankle point, and in patient with congenital rib fusions. In these cases, expansion thoracostomy and Vector are indicated. Option 5. Convex Hemi Epiphyseal disease and concave distraction. Chong and colleagues reported a retrospective 10 years follow-up study on 6 cases and reported a good clinical outcomes. Alani and colleagues have reported a similar study. They concluded that this procedure may obviate the needs of multiple osteotomies and long thoracic fusions in young children. A case illustration: 50 days old baby presented with complex deformity, curve 43 degrees at 2 years old. This procedure was performed. The patient underwent 6 distractions till 8 years old. Distraction device was removed at this stage due to implant complication, and the patient was treated with brace. The curve worsened to 80 degrees at 13 years old. Growing rods was inserted, and curve improved and maintained to 51 degrees at final follow-up at 15 years old. Option 6. Passive correction is a feasible option for patients who have attained skeletal maturity. This technique will depend on the correction of the normal segmented spine adjacent to the congenital anomaly. The ideal indications for this technique are skeletally matured, with structural lumbar curve, with significant pelvic obliquity or sacral slanting, and cases with mixed or complex congenital scoliosis. A case illustration: a 13-year-old female, passive correction with fusion was performed. Curve corrected from 85 to 26 degrees. Clinical photos show a good balance post-operatively. We have reported a series of 34 cases and show that this technique is feasible with good clinical outcome. Conclusion: congenital scoliosis is a form of complex spinal deformity, and this condition is associated with other anomalies. Early diagnosis, understanding the natural history, and appropriate surgical intervention are crucial to prevent severe deformity in this group of patients. Thank you very much for your attention.
Thank you, Professor Kwan. Vijay, would you want to proceed with the questions from the floor?
Yeah, there's one question in the chat. Dr. Srivastava sir wants to know, just one second. Have you anytime encountered neurologic deficit during the process of magnetic rod destruction? This, I think the question is for Professor Chung.
Well, thank you for that question. Very, very interesting. I think the reason for that question is when we distract, particularly if you're distracting a lot, there's a potential that we could be stretching the spinal cord and leading to neurologic deficit. But that is actually also one advantage of the magnetically controlled growing rod, because you're always, or you should be doing this distraction with the patient awake. And therefore, if the patient feels discomfort or indeed seems to develop neurology, you can stop or even reverse. That's the other advantage. You can actually reverse the distraction as well. But the short answer to your question is that no, I haven't, because I don't do, as I mentioned in the talk, I don't do a large amount of distraction. I certainly would worry. I have seen patients who have distracted 6 millimeters in one go that they develop quite significant back discomfort, which can last half a day or so, but I've not had neurology as such.
Okay, I think Professor Luo has raised his hand. Maybe would you want to ask the question?
Okay, a question for my close friend, Professor Chang. So I think it's the magic system. So I know you have. I'm very happy you have used the innovative system to the clinical practice. So actually, my question is: so do you have with distraction in 3 months or 6 months? So is it possible for you to control the rows differently with the I think it should be quite interesting for that.
Jordan, always very nice to see you, and thank you for the question. Yes, it is. It actually depends on the rod configuration. There are two rods. It's called standard and an offset. The difference between the standard and the offset rod is where the magnetic motor is inside the rod. With standard, it's at the lower end. With offset, it's at the upper end. Now, if you implant a standard and offset rod together, then you have the ability to independently distract the rod. So you're right. And I've actually done that. I have done that to help control shoulder balance. Sometimes you can develop shoulder balance, so you actually distract more on one side to try and catch up, to equal the length. Now, if you implant two standard rods, so the magnetic motors are right next to each other, then it is not so possible to control them independently.
Yeah.
All right.
Rajesh sir
I
has
think
raised his
Professor-
hand.
Yeah. Raja.
Yeah, thank you, Ken and Quan, for these excellent lectures as usual. When we discuss congenital scoliosis and this, we usually do not discuss about people who come to us with a lot of lordosis. Recently we have had a group of children coming to us with fused anterior segments and very progressive lordosis, which is actually very troublesome. And lordosis at the thoracic area actually compromises the chest cage much more because the net distance between the sternum and the vertebra become very less. What's your experience on that?
Quan?
Yeah. Yes, recently, I saw two cases, two cases on lumbar and one case in the thoracic side. So fortunately, the lordosis is acceptable. So we are still observing the patient. As what Professor Zhang and Kota have said, that observation is always the best way, all right, in dealing with this group of patients. And you only start to touch them or treat them when we have no choice. Fortunately, both of the patients are aged between 4, one is 7. So the other case, I can't remember the age. But being aged between 4 to 7, in our cases, they are still in the quiescent stage. This is a stage where the growth is has slowed down. So we have time to actually observe and to see how it progresses with time. I'm not sure, Ken, do you have any experience with this? Our three cases, we are still observing.
Unfortunately, yes. I mean, I've even had patients who have congenital lordosis, really narrow chest, who into their adulthood, 20 to 30s, become compromised, and they require nighttime ventilatory support and so on. I think it's a very bad thing, as Raja says. So I actually am relatively aggressive in trying to correct these early, if at all possible. Of course, if they are really congenital with an anterior fusion, I have actually one case in which we have distracted posteriorly, and somehow we managed to get some length in the spine with the magnetically controlled growing rod as well. I kind of show that case every now and again during talks. I don't know whether we're really stretching the bone or whether it's just a natural growth of the spine. Somehow there's some remaining growth, but I have done that too.
So just as we are talking of tether, I'm just wondering whether there is a role for anterior fusion in these people so that the posterior growth will catch up. But many of them have a lot of rib fusion associated, and that's another worry for this. Yeah. I think we have 2 questions in the chat box.
Yeah, there's one question for Professor Ken. What is the youngest age at which we should start magnetic rod, as smaller kids have high problem rate?
I think, with early onset and congenital scoliosis, it's not really a matter of age. It's actually a matter of the problem itself. And every patient is different. So I don't think you can generalize on that. My youngest patient with magnetic rods is at 3 years of age. So there are 2 absolute reasons why you cannot do it. The first absolute reason is that you cannot find anchors to put in. The bone is not big enough to put in anchors, whether it's screws or hooks. The second absolute reason is that the spine is so short that, as I mentioned, there's an actuator portion of the rod which cannot be bent, cannot be cut. So it has to be a minimum length, spine length between the 2 implants, the 2 anchors that you intend to put into the spine. It must, the 2 anchors must be further apart than probably around 80 millimeters, even for the short actuator. 80 to 90 millimeters. So that's another absolute reason.
There's a question for Professor Quan in chat box. If I can read it out to him. Since most congenital scoliosis patients require long segment fusion at very early age, do you think canal narrowing stenosis may be, or is a possible problem if we operate too early? It's a question from Dr. Vishal.
I see. Thanks for the wonderful question. I think this is It means that, Vishal, it means that by putting instrument into the spine at a very young age, causing spinal canal stenosis.
Yes, that's the question, Prof.
Oh, I see. I think that this is a very good question. As I say, it have been shown in humans and reported by Professor Ham that putting screw as young as 1 to 6 years old have no issue or no interference in human spine growth, and certainly will not cause any canal stenosis.
Kwan, if I can supplement to it, Vishal,
Yeah.
you know, one of the most important things in developmental anatomy of the spine is that the spinal canal is almost 80% of the adult size at birth. This is very surprising because the canal is of 80 to 90% of the adult size in the child, and then the whole vertebra grows bigger and bigger around it. So even if you put pedicle screws around 1 year or 1.5 years, nothing happens. We have a big series where we have put in pedicle screws below the age of 3 or 4 years. They all do very well. So you don't need to worry about the spinal canal part of it. It's only the vertical height that you have to be worried about.
Thank you, Prof. Thank you, Prof.
Thank you for the answers. There's one more last question to Professor Ken. Does magnetic rod result in progressive kyphosis in patients with kyphoscoliosis and syndromic kids?
Again, a very good question. It doesn't result in progressive kyphosis as such, but you can get particularly proximal junctional kyphosis as you distract. Often with these congenital kyphosis, we would try to correct the kyphosis during surgery by whatever, or before surgery by halo traction, by whatever means, to get the spine as straight as you can. But my only experience is that very often as you distract, they will fall off at the top. And that's not easily avoidable.
All right, thank you. I think in view of time, we will proceed with the next speaker, Professor Raja, on severe scoliosis.
Okay. Thank you, Chi, and thank you to APSS for this opportunity. So the talk is on the current role of halo, because this is the age of osteotomies. And the whole question is, although the traction is one of the most age-old and integral part of scoliosis management, what is the current role for this in the present state today? Now, the halo itself was started very early. So if you can look at it in 1959, that's long time ago, around the time that I was born actually. So, and then they had a lot of modifications on the various types of halo traction that it could happen. And at that time, it was said that it eliminates the plaster cast and it controlled the pelvis decompensation, the pelvic tilt and rotation. And this was a very common talk. But once we had internal fixation, especially after the CD instrumentation and the techniques of osteotomies, now this slowly started going away. And now the question is, does it have a place in our current scenario over here? Now we are not talking about cases like this, where you can get a very good correction by itself, but we are talking about severe spinal deformities, which we see from in our practice from time to time. And in these patients, the problem is that there is more to the problem in these patients than just the surgical challenge. Because it is actually, we are worried about the patient's physiological status also. And the challenges and endpoint of surgery are also quite different over here. We know that there are problems in spine, complex deformity. We talk about the rotation, we talk of the pedicle, the morphological changes, we talk about difficulties in getting anchor problems and the major complications. But apart from the spine itself, there is also a lot of problem in these patients. As you can see in this patient, most of them are undernourished. They have very restrictive pulmonary disease. You can see this patient over here, he is constantly coughing because he has got such a restricted pulmonary disease. They have a poor cardiac status. They are grossly undernourished. And in these patients, to do any sort of major osteotomies is a challenge to the patient's mortality itself. So what are the goals in these patients? So it's enough if we give them a reasonably good balance. They are not looking at being cosmetically perfect, not looking at the standards of our sagittal parameters normally, but they are looking at a reasonably good balance, a reasonably good correction. Most importantly, there should be good neurological safety. And we want to reduce the morbidity by just improving their physiological profile and bringing down the need for aggressive osteotomies. Now, if you go in for multiple osteotomies, then it is a well documented fact that there is increased neurological complications. As you can see in this multi-center analysis, the incidence of complications after 147 consecutive VCRs were up to 60%. And these are many very well quoted publications in literature. You can always see that the major complications are at least 20%. And these are sometimes not as severe as the cases that you actually even see. So the alternative of halo, what does it actually achieve? It gives you a gradual stretching of the ligamentous structures of the spine, the rib cage and surrounding soft tissues. And as a result, during the final surgery, the need for VCR and overall complexity of surgery comes down. And the amount of corrective force that is required, the incidence of implant failure, and the spinal cord gets adapted over a period of time, and the neurological deficit, the risk of it is actually becoming very low. So how much correction can you expect when you put a halo? Now, this is a meta-analysis, and you see that 16 studies, including 351 patients, were included. What is important is the preoperative correction due to traction alone was 25% in scoliosis and nearly 20% in kyphosis. Now, this is really quite good. And what is more important is that it is possible to do less aggressive procedures. And there was improved pulmonary function in all these patients with the traction. If you are able to get the same amount of correction, avoiding a major osteotomy, then you have a double advantage with this over here. What is the type of halo that you will use? Now, there are many different types, but the one that is most constantly used now, most widely used, and what we use also is the halo gravity traction, where the patient has a halo, and this can be done with local anesthesia and mild sedation. After application of the halo, then we don't have a traction on day 1. We start adding the weight after day 2. And with an increase in weight by 10% of the body weight every 2 or 3 days or 5 days, if the child is not tolerating it, we can go up to 50% of the body weight, depending on the patient's tolerance. And these people are on traction, either in the lying down position or sitting or the walking position. And here you can see they can actually walk, and they can be mobile completely, and they can be doing all the way, and this is very useful for them. In fact, this actually increases the confidence of these patients, and you can find that they can, if they are students, they participate in the online classes, they can write, they can do. And we stop the halo traction when there is no improvement in the radiographic parameters over a longer period of time. Now, when you analyze what is the effect of halo on all these various radiological indices, now you will find that you get a lot of good effect on some of the things that impresses the patient is the correction of the compensatory curves. You achieve it very fast, and then you get a truncal balance, and that actually impresses the patient quite a lot. And they are very happy even after a few days. The parents recognize that the child's truncal imbalance is corrected. The shoulders are looking more equal, and the compensatory curves are getting corrected. So suddenly there is an increase in height, and that actually makes them very, very happy. Now you can see the improvement in the height in centimeters. You can see that there is a good increase, and the maximum increase happens between the 2nd and 4th week. And after that, usually you see that the improvement is gradually slower and slower. And at the same time, as the height increases, the abdominal volume increases, the patient's appetite gets better, they start eating well, they have a feel good factor during this whole thing, and you can see that they are getting more nutrition supplemented, and they are more fit for surgery. Here you can see that over a period of time in the main spinal curve, the flexibility increases, the correction increases, and you get better in the compensatory curves. And there is a improvement in the resting respiratory rate, breath holding count, forced vital capacity, and also the FE1 FVC ratios. So all these actually makes the patient much a better candidate for surgery. Now this is a pictorial diagram on showing what is the effect of the halo. You will find that there is the least effect is on the main curve, but you can see that the truncal imbalance and the pelvic tilt becomes quite good very initially. There is a very good correction of the compensatory curves at the top and the bottom. There is an increase in the height. The pelvis and the shoulders become normal, and all these actually becomes very good, and it is easy for you to have a good correction over here. I have heard many patients tell us at the end of the halogravity traction, sir, if you can just fix my child spine as it is, I'm quite happy to see how much he has been corrected at this. This puts a lot of less stress on you during the surgery. You can see what is the effect of one of the sample cases, 128 degrees reducing to 92 degrees and 82 degrees to 52 degrees. And what is more important is during surgery, you will find that you are able to get much more correction easily without a big effect on it. Here in the same patient, we have operated using a cantilever system, and you can see that this patient had a very good outcome, was very pleased with the results. Another example showing two sisters with morphonoid. You can see the same effect from 134 degrees reduced to 83 degrees and corrected to 47 degrees, and from 98 degrees to 16 degrees. All these have been done, and you can be sure that you can avoid these overstretching instantly during the surgery, and also avoiding the need for osteotomy. Even in severe and rigid kyphoscoliosis, you can see that from 129 degrees, you can see that it has been corrected to 91, and finally it has come down to 71. Now, what about kyphosis? Sorry. This you can see according to the classification that we described. In patients with both column failure and where there is increased kyphosis of greater than 60 degrees, we find that in these patients, if you can put on them on a traction, you can see that the benefits of tractions are huge. And sorry, you can get a very good correction coming over to 76. A few more examples, and you can see this is the improvement that you get. I'm sorry, I just had this cough. So these are the complications of HGT. The take-home message is that it's a very useful technique over a period of time. Thank you.
I would like to thank Raja sir for his talk. And now I would like to invite Dr. Yong Hu to give his talk on neuroelectrophysiology monitoring during scoliosis surgery.
Good afternoon, ladies and gentlemen. I'm Dr. Yong Hu from the University of Hong Kong. Thank you for the invitation from the Asia Pacific Spine Society. I'm here to share our experience on neuroelectrophysiology monitoring during scoliosis surgery. In the last February, we made a clinical expert advice forum regarding neuromonitoring in the AO Spine Society. In that forum, we collect comments from major surgeons from different areas of the world. We try to discuss on the best practices in intraoperative neurophysiological monitoring for spine surgery. Learned from this discussion, I got 3 points. The first point is that intraoperative monitoring is a kind of practical science, which mainly based on experience of clinical monitoring practice. Secondly, we all accept the combination of Icp, MEP, and EMG as the standard setup for monitoring. And the last but very important issue is that the monitoring reliability is based on the close collaboration among monitoring specialists, surgeons, and anesthesiologists. As well, the surgeon would make the final decision based on the patient's situation and the different consideration of surgical operation. Based on my experience, I usually take a different strategy of monitoring in the different patient. I will consider patient with or without a neurological problem as 2 considerations. In consideration of neurological normal patient, I will check baseline first. If the baseline didn't show normal signal, it will be considered about the technical problem. I will verify the recording protocol and to establish reliable baseline first. During the monitoring, I will take a regular monitoring schedule, which is not very frequently. And to decide the abnormal monitoring outcome, I mainly consider about the abnormal ICP presentation, because ICP have a high specificity in the monitoring in scoliosis. Let's see one case with a normal neurological function. In this case, is a short segment fusion with correction of scoliosis. We perform ICP and MEP monitoring for this case. After the placement of T10 pedicle screw in right side, we found the drop of MEP signal. Later on, SEP signal also drops. So we confirm that is neurological loss due to the pedicle screw placement. After remove of this screw, the signal returned to normal, and then we close the surgery. This patient show normal neurological function. It's very lucky. In consideration of patients with abnormal neurological function, I will take another strategy of monitoring. So in this case, I will perform IOM in both MEP and SCP continuously and at the same time during the practical procedure. and I will take care about the warning in a less sensitivity situation. That means I will decrease the warning criteria a little bit. Here, I will show you a neuromuscular scoliosis who appear motor dysfunction in lower limb before surgery. That's why we do not expect have a very good baseline. Even we can have a largely normal SEP baseline, but we have a very variable MEP baseline for this patient. So in some way, this patient showed the disappear of MEP in some muscle from time to time. So we will slow down the operation procedure and also ask the surgeon to make a careful correction. And we guarantee the MEP waveform maintain the normal value during the surgery. Luckily, this patient got no neurological problem after surgery. In summary, I will say intraoperative monitoring is mainly based on a practical experience. So clinical training, our monitoring specialist is necessary. And also, more training courses and case discussions among monitoring specialists are key to improve the quality. Since the limitation of high-level evidence-based LM study, due to larger individual difference and few positive cases and also the limited validation, because we cannot make sure about the spinal cord injury during the surgery in the human body. So a large-scale multi-center collaborative study and rigid study design is needed. So I would call for your attention about these three issues to support the training of our monitoring specialist, and also welcome to join the multi-center study about the monitoring. Thank you.
We would like to thank Dr. Yong Q.
Yeah, proceed, Vijay.
Yeah, floor is open for question, and Dr. Lu has raised his hand.
Oh, yes. Thank you. So my first question is for Professor Raja. So actually, the halo gravity traction is still used in my department. The most of people was tracked in months, but a few of them were tracked a longer time, but 2 months, even longer. So my question is, so is it possible for us to have the first stage surgery for the patients to do some multi-Ponti surgery to relieve the fixed deformity, to accelerate the traction procedures, and then we do the final surgery for that patients?
Yeah, thank you for this, because this is a very important aspect when we are discussing the halo, the long preoperative traction. So I used to have an inhibition in my mind to discuss this prolonged traction with the patients till I went to Ghana, and there I saw Professor Boachi. And when I went to his focus hospital, I saw about 45 kids on traction. And Boachi used to put them on a traction and then go off to America and then come back after 4 or 5 months and operate on them. And when I discussed with him, he said that is the actual reason for his success. And he said, if you don't want to put them on traction for 3 months, then don't put them on traction at all. And that changed our concept. If you're going to put them on traction for a shorter period of time, then it may not be so useful. But one way I have found nowadays convincing the patient is that even if you tell them, putting them on traction is going to get your child 20% more correction and it is going to be 30% safer in neurological deficit, they just immediately accept. We have not done any initially pre-release procedures or some preliminary operations and then put them on traction. We just put them on traction and then take them up for the final surgery.
Yeah,
Thank you, Raja. Thank you.
Yeah, I think Lau, did you raise your hand just now?
Thanks, Prof. Raja, for excellent talk, and hope you get well with the cough. And also, in regards to the tractions, we do traction here as well. During the pandemic period, does it affect your workflow? Because the traction period obviously will be consideration in view of hospital bed shortage, right?
Yeah, so our hospital is not a COVID hospital. So we have no issues regarding that. And the number of patients who came in for scoliosis surgery during the pandemic period was itself very low. But after the pandemic was over, we had a series of patients with a lot of huge deformities because they have not seen any doctor for 2 or 3 years. And they had left their scoliosis to deteriorate. And so we had a huge series of patients, more than the normal ratio of patients who required halo after the pandemic. But the more and more we use halo gravity traction, we have started loving halo gravity traction more and more.
Is there a particular group of patients that you totally would not do a traction at all?
Sorry, say again?
Is there any particular group of patients that you will not do traction at all?
Yeah, persons who show good flexibility. Of course, if they are going to have a curve less than 100 degrees, we won't put them on traction. If they are even more than 100, but they show a flexibility where after a traction film, they are showing a reduction up to 60 degrees or something, then we won't put them on traction. So it is only the persons who are having a gross rotation, kyphoscoliosis, and also who are rigid, and who have also got a tremendous amount of truncal shift. These are the patients whom we put them on traction. And we would prefer them to be in the hospital for traction because you can have a good supervision over there and you can actually accelerate the increase in weight when you have them right in front of you.
Hi, Raja. Yeah. Hi, Raja. Great talk. Do you have any experience with halo pelvic traction? Since I know that you have enormous number of severe kyphotic deformity in your center, and if you have the experience of halo pelvic traction, can you share your regime and how to actually lengthen the halo pelvic?
Yeah. So our experience with halo started with halo pelvic traction, but unfortunately that experience was short-lived because the incidence of complications at the pelvic level was very, very high. Now, many of these children who required a prolonged traction, they are very small made and their pelvis is actually very small, very thin. And when you start to distract that, then they have a huge amount of problem. Second is the halo gravity traction. Something very good with it is that the patient can comfortably lie down. There is no problem with sitting, there is no problem in lying down. And as I showed in the slides, they are quite comfortable attending their online classes. They can sit and do their homework. They do whatever they want. It is just that the traction is attached to them all the time. The halo pelvic traction is not like that. I mean, they have gross problems and serious problems in sitting. Their lying down and sleeping times are very uncomfortable. And these children keep moving and the incidence of pin tract infections and the pelvic bone loosening is very high. So that's why we have completely come out of halo pelvic traction. It's not comfortable for the patient at all.
Yeah, thanks.
Yeah, I think Professor Kai Chow, you have raised your hands.
A question for the Prof. Raja. According to your clinical experience, could you tell us the difference between the hollow pelvic traction and the hollow gravity traction in aspect of the destruction power?
Yeah, we have not actually compared a specific group in hollow pelvic and hollow gravity, because if we have to make a comparison of the efficacy of these two methods, then we should have compared them as to their initial curve magnitude, their flexibility, and all that. We don't have a similar comparison. We don't have the result because we did it initially with hollow pelvic and then completely switched over to hollow gravity. But what I have found, I mean, not giving you the quantitative numbers, what I have found is I think the hollow gravity is far superior in patient comfort. Secondly, they improve much better on the respiratory rate. The patients have become very, when you put them on a hollow pelvic, you have to have a happy patient. Only 50% of them are happy. Most of them are constantly complaining. But the hollow gravity patients become very happy very fast because within a few days, they find that the respiration becomes much better. Their breath count becomes much better. The resting respiratory rate becomes much better. They start eating well. They digest well. The quantity of food that they are taking becomes more. And both the patient and the parents become very happy with that. This kind of quick improvement I didn't see in our hollow pelvic patients. So I'm not able to give you a quantitative data, but I would prefer that the hollow gravity is far superior to hollow pelvic.
Yeah, because in my experience, when I faced to the severe reached adult scoliosis, we use hollow gravity traction. I think it's not be satisfactory to get a satisfactory destruction when we use the hollow gravity traction, because I think maybe the adults severe deformity is really rigid. So in that scenario, we use the hollow pelvic traction. So yeah, that's my opinion.
What was the group of patients and what was the average age of these patients?
And the adults severe reached deformity, but in the child we use hollow gravity. Yes, but for the adults we use the pelvic.
Okay, if it is an adult, I think there is a scope for hollow pelvic, but most of our cases are children, and they do very poorly with hollow pelvic. And when a complication occurs at the pelvic side, it's very painful. It becomes extremely painful and you lose the confidence of the child.
Thanks.
Okay, maybe one last question from Professor Zhang.
Yeah, I have a question for Professor Hu. I want to know UMEP alerting criteria in Hong Kong U. So what's your experience?
Okay, thank you for your question. Actually, for the as I said, there's I found that the previous criteria for the monitoring is quite difficulty because we face on quite a lot of false warning and the false positive and false negative. So currently, I try to establish different criteria for different kind of or maybe different classification of the patients and the surgical approach. So we are now trying to establish something new regarding this thing. Usually, what we learned from the conventional monitoring is one criterion for every monitoring. I think that is not very reasonable. Okay, thank you for your question. We are trying to do so.
Thank you.
All right, thank you very much, Professor Yong, Professor Raja. We move on to the case discussion in view of time constraint. So the first case presentation will be by Professor Chris Chan on congenital scoliosis.
Thank you very much to the society for the opportunity to present in this webinar. I have no disclosures. So this is a 10-year-old boy prior to the surgery. He first presented in 2014 at the age of about 3 years old and complained of a hunchback. He was diagnosed with the Pierre-Robin syndrome. He has intellectual disability and he goes to a special needs school. He has a cleft palate which was repaired at the age of 1 year old. He has a horseshoe kidney and he has some eye condition, namely anisometropia with the right eye esotropia. On examination, he has a facial dysmorphism. He walks normally. The lower limb reflexes and abdominal reflexes are normal, but Babinski is downgoing. Motor power is generally 4+, but he's not able to follow instructions well, and we are unable to test for sensation. This is the X-ray at presentation. This is a supine film. So for future references, this is where we did our measurement, one level above and one level below the congenital abnormality. And in this film, it measured 52 degrees of regional kyphosis. So over the years, he progressively worsened. In 2018, the erect film shows a regional angle of 67 degrees, which progressed to 72 degrees in 2019. And prior to surgery, he was 81 degrees on the erect film. So from the AP film, in 2018, there was a mild main thoracic curve of 22 degrees. In 2019, the curve was 19 degrees, and prior to surgery, the erect AP film shows a main thoracic curve of 35 degrees. The CT scan showed that at L2, on the right side, there's a complete lamina, there's a complete pedicle, but there's a deficiency in the vertebral body. Whereas on the left side, similarly, there's a complete lamina, complete pedicle, and deficiency in the anterior vertebral body. On the right side, there's a laminar fusion between L3 and L4. On the left side, there's a laminar fusion between L2 and L3. The patient has 12 ribs. The S1 has undergone lumbarization. The MRI shows there's no neuroaxial abnormality, and the patient has a single kidney as demonstrated from the MRI. These are the flexibility radiographs. From the fulcrum lateral view, the regional angle corrected to 68 degrees from 81 degrees. Right side supine side bending film, the main thoracic curve corrected to -12 degrees. On the left side supine side bending film, the lumbar curve corrected to 9 degrees. So the diagnosis for this case is a Pierre-Robin syndrome with congenital kyphosis secondary to bilateral L2 hemi vertebra with an angle of 81 degrees with compensatory scoliosis of 35 degrees without any neuroaxial abnormalities. So I'll open the floor for the discussion for the panel.
Yeah, so I think we encourage every speaker to contribute your opinion. Is there anyone who wants to comment on this case? What is your opinion and what would you do?
Hi, Chris, Lachlan here. Very good presentation. So 10-year-old Pierre-Robin syndrome. Pierre-Robin usually may affect your mid-facial area. So sometimes you may have ear problem as well on top of the cleft palates. So 10-year-old, what I want to know in this situation is that what's the truncal height? What's the also the T1 to T12 distance?
Okay. Yeah. Thanks a lot for the questions. He's I don't have the exact measurement, but he looks short compared to the parents. But I think that what you mentioned is very important, the measurements of the trunk length. But it is not so much affected because it's a focal lesion, only over L2.
Symptomatically, is there any concern in terms of pain?
No, patient does not have any complaints of pain. Patient does not have any other complaints of any neurological symptoms.
Right. So it seems like the predominant problem is that of kyphosis with some element of scoliosis.
Yes.
And in the presence of congenital curve, right? And then, of course, I think early on, Kwan mentioned about cardiac involvement in congenital scoliosis or kyphoscoliosis. Any problem with the heart?
Yeah, there's no cardiac lesions. So maybe we can listen to the rest of the panels who have presented before this and discuss what are the ways which they would actually approach this case.
Maybe I can ask Professor Zhang. Do you have any comment on this?
Yeah, I think the diagnosis is quite clear. It's a syndromic scoliosis. But the main problem is the posterior hemi vertebra. So that's why it showed severe lumbar kyphosis. I think for this patient, I think surgery is needed. What I'm doing is do posterior hemi vertebra resection, 2 levels above and below fixation. And since this is a very posterior hemi vertebra, anterior reconstruction is necessary. I usually use the mesh cage together with this self-bone to do anterior support to get a good correction and also a very good stabilization. Yes, thank you.
Okay, Professor Raja, you have raised your hand. Do you want to comment?
I was going to say exactly what Professor Zhang said. So he said it all. So this is actually surgically not a big challenge because the anterior or A formation is there, but posterior structures are okay. The good thing here is the pedicles above and the above and below levels are very good. So fixation points are not a big problem. So it's quite easy to do posterior only surgery and then do a complete resection of the hemi vertebra. Just that because there is also a scoliosis element. If it's only a pure kyphotic element, sometimes 2 above, 2 below is okay. Just there may be a necessity to have 3 above to correct the scoliosis element, but that's optional and we can keep it that decision when you're operating. But in all posterior, 2 above, 2 below, with anterior reconstruction, a cage probably will be my option. Just as Professor Zhang said.
Yeah, since Professor Rajan brought up the scoliosis, there's a thoracic scoliosis of 30+ degree. What would you do Professor Kwan? Okay, Professor Raja, you can.
Now, your question is about the thoracic scoliosis?
Yes, about the thoracic scoliosis. What would you do? Would you leave it alone? Would you attend to it when you do the hemi vertebral excision?
I don't think I would concentrate on that because if you're going to address it and extend your instrumentation in a 10-year-old boy, I think that will not be ideal in my mind. Here, I would like to ask the same one question. What is the most important problem for this patient? And just address it at this period of time. I wouldn't like to make a long fixation and extend this to thoracic in a 10-year-old boy who's already very short.
Professor Kwan, you have raised your hand.
Yeah. Thanks, Chris, for sharing a very interesting case. Actually, this is a very interesting case. You look back to the X-rays of how the kyphosis developed. It followed a classic McMaster and Singh's publication on the natural history of congenital kyphosis. All right. For a posterior hemi, single hemi, the average deterioration of the curve is somewhere between 2 to 5 degrees. So in this case, it's about 3 to 4 degrees a year. So therefore, the curve has deteriorated from 50 to 70 in the short duration of 6 years. And this is a very important message because during counseling of the parents between this age of 3 to 9 years old, we can actually tell the parents that these are the amount of angle deterioration and whether the parents are willing to, accept the surgery early or wanted to delay the surgery. I think the reason that the kids are being subjected to surgery is because of the growth spurt. And within a year from 9 to 10 years old, somehow, the angle has deteriorated 10 degrees. So therefore, at this point, surgery is inevitable. Point number two I'd like to make is that from the MRI, something very interesting you can see that is that the spinal canal is not, the spinal canal alignment of the posterior vertebral wall are not the alignment is not good. So this sign is called a step-off deformity. Itself is an indicator of high risk of urologic progression in the event that the kyphosis worsen. So for this case, certainly, surgery need to be instituted. Reason being that these are the high risk group for neurological deficit if, let's say, being neglected. So on how to address what type of surgery, I think Professor Chang and Raja have already voiced their opinion, is resecting the Hemi Vertebra anterior reconstruction with 2 levels on top and below fixation. Thank you.
I think for the want of time, we can go ahead and I would request Dr. Chris Chan to present what was done.
Thank you very much to all the opinion from the expert panelists. So we perform a pedicle instrumentation on the right side. It's at above the Hemi vertebra is from T12 L1 and L4. The reason we skip L3 is because the L3 L4 lamina was fused, and it was actually in the way of each other. So we chose to insert L4 screw only. On the left side, we inserted T12 L1 L3 L4 screw with bilateral Hemi vertebra excision and block. So this after exposure and after the screw insertion. So this image actually shows the right and left Hemi vertebra and its relations with the right and left L2 nerve roots on right and the left side. So this is the location of the nerve roots. So after excision, this is the both Hemi vertebra excised, and this leaves a gap whereby we use the persuading system and compression system to close the gap before we actually perform posterior fusion. And of course, to close the gap, we inserted a big piece of bone which we obtained from the lamina to close the gap. This is a patient day 1 after surgery, and we place the patient on the brace before discharge. This is a post-operative X-ray at 6 months. Erect X-ray before surgery 35 degrees. The main thoracic curve remained at 39 degrees. The regional angle was corrected to 16 degrees after the surgery. 6 months CT scan shows there's actually fusion. We actually used the Hemi vertebra block, and we actually reinserted into the gap in front, and this has actually helped to augment the fusion process. So the limitation is that we are still waiting for the longer follow-up. We are not sure what's the residual main thoracic curve outcome. And of course, when you perform a correction in the sagittal plane, there's a possibility of proximal junctional problems. Thank you very much.
Thank you, Professor Chris. In view of time constraint, I think we'll move on to the next case. Okay, yeah. Would you want to introduce?
Yeah, Dr. Neeraj from India would like to present about neurofibromatosis 1 scoliosis. The floor is yours, sir.
Thank you, APSS. Thank you, Medtronics. Can you see my video? Can you see?
Yeah, go ahead, Neeraj.
So, good day, everyone. So this is a young male of 17 years old with neurofibromatosis in his family. He has cafe-volute spot over his back. He has severe deformity on right side with shoulder and hip imbalance. He was slightly shifted on right side by 5 centimeter, and the thoracic hump was almost 32 degrees. So these were his X-rays. So his major curve was 126 degrees, and others curves were 65 and 53 degrees. On traction, it was stretching from 126 to 110 degrees. There was a kyphosis of 65 degrees. So I want to take the opinion of the panel. The CT and MRI was normal for this patient. So what could be the treatment options for him?
Yeah. Anyone in the panel would like to comment on this? Maybe we'll start with Professor Raja.
Okay. So because the first question was, would you use halo? So I would take that. So that we know that this is a problematic case, not just because the dimensions of the curve, but because of the other many problems that neurofibromatosis curves pose to us. The pedicles, when you correct a curve like this without an osteotomy or without a halo, then one thing that you would require is multiple and strong fixation anchors. And this is sometimes very rare to get in neurofibromatosis. In long-standing neurofibromatosis, over this whole area of the apex, you will find that the pedicles are completely thinned out, or they are very atavistic, or they have become highly sclerosed. And also recently, we have come out with two publications, I think one in European Spine Journal and another is in Spine Deformity. We have classified the morphological changes and types of pedicles in neurofibromatosis. And so in many areas in the apex, you may not be able to get good anchors. And that will make it a big deficient or disadvantage for you to exert a corrective force. So I think this patient is a very ideal patient to get as much correction. And these are the patients who don't have a congenital problem, who don't have a bar or who don't have a tether. And these patients will show a good correction with halo. He has got a kyphosis, he has got a scoliosis. Even with traction, it is 110 degrees. With halo gravity traction for a few weeks, you will find that you get it to at least 60 or 55 degrees. But what's more is not what you have achieved, but the whole curve becomes so flexible that further correction during surgery is very easier. I would certainly think he is a good candidate for halo gravity traction.
Any panelists with different opinion? Somebody wants to go for anterior releases or a two-stage procedure?
For myself, I would consider a few things. Number one is that you said this is an F, right? So we got to make sure that this is not a dystrophic curve. So MR and CT scan will clear that out for you. If it's a not dystrophic curve, then of course, and you've got to make sure that there's no neurofibroma within the canal itself. And if all these are clear, my approach in this situation will be a stage approach. One of the limitation in our setting is that the halo gravity tractions, it reached a plateau about a month. It was presented by Prof. Raja early on, and 2 months by Boachi's group to reach a steady state of about 30% correction. So in our setting, we can't afford this kind of like a hospital stay. So in our setting, often what we do is that we do anterior release for the patients, which means that in this case, this is in a Boachi classification is 1C curve. You can expect about 30% correction with halo gravity traction. But if you were to do an anterior release as a stage procedure and followed by halo gravity for around 5 to 7 days and go posterior, you could achieve a similar outcome as what you would done with the pre-op halo gravity traction alone. But notably important is that you need to do chest releases adequately. That means that the ribs must be resected both sides in order to assist you to get more corrections. And of course, not to mention that you have to do a spinal releases, including pontic osteotomies, generally. That will be my approach. Thanks.
Right. Can I proceed with the case?
Yeah,
you can proceed. The MRI or the CT of this?
It was absolutely normal, and with the restriction of time, I avoided to put extra.
Sure, okay. If they are normal, it's fine.
So all these management options were open to do a stage releases and definitive correction. So we have, this was a long time before. At that time, we were not doing many halo gravity tractions. So we have gone with a single stage extensive releases, pontes and facetectomies and T2 to L4 fixation in a single stage. So on positioning, the neuromonitoring was good. All pedicle screws from T2 to L4 has been instrumented. Screw position was found to be acceptable. All the pedicle walls were checked with neuromonitoring triggering, Also, all screws were triggered. It was fine. So at this stage, all screws are in, all releases has been done, and neuromonitoring was good. So the problem started when we started placing the rods. We put a rod with a cantilever technique on the concave side. We started on the concave side, and first rod was in with all screws were locked on the concave side, and we have got a decent correction. After 10 minutes, we started losing the signals. So we started losing the signals in both lower limbs with first rod placement. So all the measures were taken, rods were removed. The concave rod was removed, second rod was not placed at this time. And we were managed to reverse this neuromonitory signals in after 15 minutes. It was back to normal. So we have to recheck all the screws with borderline with II check and neuromonitoring triggering. 2 doubtful screws were removed. So one was at the apical and one at the UIV. So 2 doubtful screws were removed, and again we tried to insert a contour rod with in-situ fixation on the concave side. Second time our signal lost with in-situ fixation on the concave side. So, and it returned back immediately after removal of the rod. At this status, we have no rods, all screws are in, neuromonitoring signals is normal, and we have it get back after losing the neuromonitoring signals second time. So if anybody wants to comment at this stage, so all this, only 2 options we have at this stage to abandon the procedure, because we have lost 2 times the neuromonitoring signal, though it is back to normal. We can re-evaluate the patient with CT, MRI, check the screw positioning, or do something else.
Anyone from the panel? Professor Kwan, Professor Raja?
Yeah. I mean, these are situations where we get into once in 5 years or 6 years, and every single time you decide on your gut feeling at that stage and also the case to case. So you said you place the concave rod, concave side first.
Yes, sir. So first we placed in a straight rod with a coronally straight rod with a sagittally contoured rod of desired correction, and the signal was lost after 15 minutes. And second time, it returned back, and second time we put in situ rod, sir. So still lost.
Okay. So I would actually place not a, then if you're putting a rod which is completely over the whole entire segment, sometimes this happens in this stage, I would actually put in a shorter rod just to look at the apical level itself, try on the concave side, on the opposite side, to stabilize it a little bit and see. If that also is giving a problem, then I would accept this. I am not worried about. You have done multiple Ponti's osteotomy?
Yes, sir. Yes, sir.
Okay. I would still just close the wound and then think in terms of either taking him up after some time, because Lenke has told many times in conferences he has lost signals for unknown reasons, but when they go after a week or 2, the whole surgery goes flawlessly without any problem, and you just wonder why the signals were lost in the first place. So you would try that again, or in the meantime, you can even put in him on some traction and gradually get some more correction.
Right.
And then you can go in again and do accept a partially corrected correction.
Thank you, sir. Any different opinion, panel? Anything to add on?
Neeraj, would you consider do a wake-up test for this patient?
So we have got new signals, all the signals back as normal findings. So we didn't find a use of wake-up test at this situation, though it is.
Also, after you removed the rods and the signals all came back.
Yes, it all came back second time.
Right. Okay. So I got it. What I did is was similar to what Raja suggested.
Okay. Okay.
Maybe you want to show what is done next.
Yeah. So what we did, we have gone with a convex contoured rod and we have placed slowly one after another, and the signals was as it is. We did after fixing the convex side first, then we have gone on the concave side with in situ rod fixation. We have tightened all the screws; those signals remain normal, and we've confirmed everything on wake-up test. And these are the final pictures of this patient. He is absolutely normal, back to work.
Oh, very good. Yeah. So thank you for the case. So I think in view of time, we will move on to the last case. Yeah. Okay, by Dr. Lau Leok Lim on severe scoliosis in non-ambulatory patient. Thank you very much.
Dr. Lim, you're muted.
Thank you very much, APSS, for the invitation. I was given the opportunity to present neuromuscular scoliosis, and I realized that no one has presented a lecture in that, so hopefully you can bring up some points across. So this patient first saw me when he was 11-year-old plus 6 boy, and presented with a background of equine varus, had a surgery done, and no perinatal complication, no issue with the birth history. Diagnosed with Duchenne muscular dystrophy on DNA analysis at the age of 5 years old. Had the left eye cataract on follow-up, and no family history of this condition. Has got a younger brother and 2 elder sisters. In terms of modern milestones, he walked at the age of 1 year old, unable to get off floor at the age of 6 years old. This will constitute a Gower sign. He was not able to stand up from chair, climb stairs at the age of 8 years old. Became a furniture cruiser since 8 years old, used a wheelchair since 9 years old, completely wheelchair bound at the age of 10 years old. You can see a picture on the right side. Is what he looks like when he saw me. He's using this wheelchair, motorized wheelchair with the console that he can control using his upper limb and fingers. In terms of treatment history, he started on prednisolone at the age of 6 years old when it was diagnosed. Subsequent to that, he had an enalapril, zoledronic acids at the age of 8 years old. So on examination, on wheelchair, he was comfortable, alert, was able to use, complete a sentence without issues. He's well hydrated, heart lungs were okay, and no bony tenderness. On examination, he had a flaccid tone, quadriceps muscles were wasted. He's got pseudo hypertrophy of the calf muscles. And he's got proximal myopathy of upper and lower limbs. Proximal muscles of the upper limbs were grade 2, distal were grade 3. For lower limbs, proximal muscles were grade 2 and distal were grade 3. His hyporeflexia, Babinski was negative. Functional status, as mentioned, can use the right hand to control the console of the wheelchair. And in terms of physical examination, the weight and height were below the 3rd centile. You can see that his height was way below and his weight was around 20 kg. Right, so on investigation, right hip was partially subluxed, about 50% remorse index, and he's got a curve, a sweeping C-shaped curve running down from top to the pelvis. Measurement was 59 degrees. On follow-up, 11, 12, 13 years old, the curve became progressive from 59 degrees up till about 65 degrees. At every stage, surgery was advised, but they declined. So finally, it came to this stage when the curve became 100 degrees. Pelvic obliquity is 23 degrees. The physiotherapist and occupation therapist had a hard time to put him on a chair. And that's the time that they come here and decided to consider the option of surgery. And on investigation, bone mineral density was done. As you can see in here, that the T-score and the Z-score were both extremely low. It's in the region of negative 3.6. And lung function test was done serially. Latest was 28.4%. Nutrition assessment was 44 albumin, which was normal. So cardiac function, 65% with no cardiomyopathy. So in summary, it's really a 15 plus 11-year-old male, early non-ambulatory Duchenne muscular dystrophy patient, de novo. flaccid kypho scoliosis with the thoracolumbar scoliosis measurement was 100 degrees, with pelvic obliquity 23 degrees. Has got right hip subluxation, reasonable cardiac function, poor pulmonary function, and secondary osteoporosis on treatment. So what are your considerations and what would you do?
Maybe I open all this to the panelists. Anyone who want to comment? Prof. Kwan,
Yeah,
would you like to comment?
yeah, thanks. Thanks for sharing a very good case. All right. What is the patient education status?
He is a homeschool. He is a very intelligent man.
Okay. How about the parents?
Parents were very intelligent as well, and has been schooling him. But of course, the reason of delaying surgery at every stage was because that they were concerned about the risk of operations.
Yeah, right. So I think that for this case, the whole issue is that this is a case that indicated for surgery. The reason of surgery is very obvious, all right, is to balance the patient for better sitting, as well as to prevent the pulmonary function. And this group, Duchenne, their pulmonary function will deteriorate with time. So having a surgery done certainly will protect the pulmonary function, all right. We don't have many experience of Duchenne cases in our hospital. In the past 15 years, we have 1, 2, 3, 4 cases so far. Similar curve exactly look like this patient, all right? So the fusion is a very long fusion, usually from T4 up to the ilium, long fusion to correct the pelvic obliquity as well as the kyphosis. Reason is, as I mentioned earlier. So in this case, we have to deal with the parents, inform the parents regarding the risk, all right, of the surgery, which I've listed very well just now. Include nutrition, respiratory function, which is very, very poor bone quality, and the underlying medical problem itself. So it's a standard surgery, but the problem is you are dealing with the multiple medical issue that the patient is having, and that will increase the risk of this operation.
Thanks, Professor Kwan.
By the way, I got feeling that the PO is not 23. If we use the Melanie technique of measuring the PO, in this case, I think the PO is approximately about 70 to 80 degrees. Practically, the whole body is sway away from the parallel to pelvis.
Yeah. If Professor Raja, if you're around, would you want to comment on this case?
Yeah, I think I agree with whatever Kwan said. Surgery is imperative because you can see in this picture there is a gross truncal imbalance, there is a costocrystal impingement, the rib cage on the right side is actually going inside the pelvis, and the hip subluxation is becoming more. So luckily his albumin and nutritional status is okay, his cardiac status is okay. The only concern is -3 BMD. I think that could be adjusted with putting more screws over, or larger screws in these patients. The whole question is whether you would include the pelvis or not. The pelvis inclusion is more safer. It makes them, but he is non-ambulatory. So I think that is not a major consideration. So go in and do a straightforward fusion and correction is okay.
Yeah, thank you.
Now, is there any question in particular limb that you would want to raise in this patient?
I'll go through what I've done in considerations.
Yeah.
Lau, do you have any flexibility films?
I do. It was very flexible. Bends down to about 30 degrees.
Okay, maybe Lau, can you show us what is your consideration?
One question before we go ahead, Chris.
Oh, yeah, okay.
To all the panelists and even the faculty. Now, since these bilateral hip dislocations are seen, if we include the pelvis, we will take away the mobility from the L5 S1 junction, which is probably helping him to sit now. So is that a concern that the moment we fix in pelvis, his sitting abilities also may get partially compromised and will rely totally on the dislocated hips rather than any pelvic movement which is currently present?
Probably not. I think I agree with what Raja said. If you are ambulant patient, then of course the issue always at your hand is that when you extended the pelvis, whether it will affect the remaining ambulation function or not. In this age group currently, they are non-ambulant, so it's not in consideration. But the key consideration, of course, is that should you do hip first or should you do spine first?
I agree with you, Lim, because the question of whether you go into the pelvis or should you give that certain amount of mobility at the lumbosacral junction is a very vital factor in patients who are ambulant, because that movement is very important for them to get out of the chair and come out. But in a non-ambulant patient, it's not so important. So I would actually rely more and tilt on the side of going up to the pelvis. If he is non-ambulant and the hips are not painful for him, so I would not go on hip first, I'll go on spine first.
Right.
So if you go on the hip, the outcomes of doing any hip surgery in paralytic dislocations are so, it's not a very straightforward operation. What operation you do for that is a problem. You have to go into the acetabular morphology, and there are so many issues associated with it. And that will be a key factor if the hips are painful. So if the hips are painful, I would first tackle it first. But if the hips are not painful and the patient is not aware of it, then I would actually operate the spine first.
So Lau, is a hip a problem?
Hip in here is a subluxation.
Yeah, but is that pain? Is it disturbing the patient?
It's not a dislocation.
Is it disturbing the patient at this point?
Main issue that he had was that he said that his feet was bothersome and he has got to wear the AFO. Otherwise, the hip is not bothersome.
I see. I think if a hip is not an issue, then you shouldn't address it first, because sometimes having a dislocated hip is good for them as well.
Yeah, exactly.
Right? Because there's you have a dislocated hip. It's actually better in terms of their sitting position.
Exactly.
Occasionally.
Hypermobile.
So the second point is sorry, Raja. Sorry, Raja, go ahead.
No, hypermobile painless hip is not a big issue for them.
Yes.
If you have a unsuccessful hip operation in these patients, it can become a stiff, painful hip.
Okay. Maybe I can also raise a point about neuromonitoring in this sort of situation. Would our neuromonitoring expert monitor this patient, neuromuscular cases?
I think Professor Yong, who is not have left, due to certain personal reason.
So, but Lim, you see, the two good things over here is that you said it's a very flexible spine.
Yes.
And so from whatever is this curve, 100 degrees curve is actually reducing to, you said it's less than 30.
It's around 30 degrees, very flexible.
So
the pelvis is not so flexible.
Yeah, so I wouldn't be so worried about neuromonitoring. If the neuromonitoring is not showing signals, I wouldn't be too worried about it. I would still go ahead with surgery.
Okay. There's one question from the chat group by Professor Srivastava. What is the survival period of this patient? Lau, do you have any?
With the prednisolone treatment, they survive until about 40s or even longer now. Prednisolone is a single most important treatment improvement for Duchenne patient. That and the progression has been controlled, and therefore we've been seeing less and less of these cases. He represents Duchenne, rather the steroid-resistant type of situation.
Okay. Maybe can we proceed with your what you have done or what you have?
Okay. So I'll move on. So the consideration, of course, pre-op consideration, we do a benders. I mentioned to you that was rather flexible. the thoracolumbar curves reduced down to 38 degrees. The pelvis itself remained quite rigid. It's kyphoscoliosis, and I did a CT scan. CT scan, you can almost see this picture frame appearance, similar to Paget, without the coarse appearance of the cortical bones. So there's a very good definition between the trabecular bone and also the cortex, suggesting it's quite a severe osteoporosis. And I did a CT scan of the pelvis as well to see the windswept pelvis. I can see that the left side is more vertical than the right side. Right side appear to be more normal. This will affect how I instrument the pelvis. Some of the warning criteria for complications in neuromuscular scoliosis are all listed in here. If they're very thin, they are very, very big size, there will be a concern. If their pulmonary functions are poor, heart disease, you're going to have problems. If they're clotting issues, you may have a problem. Of course, if the curve feature is such that they are very big or they're very kyphose or even very, very hyperlordotic, you're going to have issues as well. So these are the warning risks that you may ask for help or even may not proceed with the surgery. So what are the issues that I consider? I need to optimize lung function, bone density, and cardiac function. So of which he was referred to all my esteemed colleagues in the hospital to optimize. He was started on IV pamidronate and zoledronic acid previously. And of course, hip versus spine, we discussed that already. It's a painless hip subluxation, so I left it be, and I often, even it's dislocated, I usually go with the spine first before the hip. Anesthetic concern, you need to refer to an anesthetic colleague because there's a chance of malignant hypertension or hyperthermia rather with the use of certain agents. And blood conserving strategy is utmost important because they lose quite a fair bit of blood. Neuromonitoring sometimes may not be so useful in patients, particularly CP patients. Surgical options ranges from the older techniques using Galveston technique to the segmentation techniques. Of course, anterior versus halo tractions versus cementation, screw density, these were part of the consideration. iliac screw versus SAI screws, I prefer to use iliac screw. Of course, spinal alignment targets are important. They have some residual function in them. For example, in this case, this boy could use her fingers to control the console, and they can use a long devices to fit himself on the mouth as well. So you don't want to make them too straight. If you're making too straight, then that hand to mouth distance will be affected. Post-op consideration will be includes mattress, hoisting, get in the car and get home. So all these are the things that I consider before surgery. Positioning of a patient will be difficult. Patient has got the hip contracture. Some of them may have even have baclofen pump if they have CP. So that's how typically I position a patient. I use a sling in the Jackson table, and that allowed me to put them in the almost seated position. And in this case, I did a T3 to L pelvis. The estimated blood loss was around 800 mils. This will be approximately about 40 to 50% of his total blood volume. So you can imagine that you have to use all sorts of techniques to minimize that, including hemodilution, and also at the same time use the cell saver. And in this case, we got a significant amount back to the patient. Of course, tranexamic acid is very important in this situation. Bear in mind that the smooth muscles of the vessels were not working, and so they don't get constrictions after the vessels is being cut. So 2 weeks post-surgery, this is the alignment I get before the optimization of the sitting on the chair position. I did posterior instrumentation from T3 to pelvis. I did Ponte osteotomy from T12, L1, L1, L2, L2, L3. And a year later, this is what I get on the X-ray. Of course, my colleague carried on with zoledronic acid. You can see that bone mineral density has improved from -3.6 to -2.7. Strategy during the surgery I use includes higher density, and at the same time, I also use long arm screws, particularly at the thoracic region. Poly screws are a must and in the thoracic region. In fact, in this case, I thought that I should have given him a little bit more thoracolumbar kyphosis to lower down that hand to mouth distance. So far, he's been doing well. He's about almost 2 years post-surgery already. So that's what we get. Thank you very much.
Congratulations. Wow. Great work.
Yeah,
Congrats.
Yeah, look perfect.
looks perfect.
Yeah. Thank you very much. I think we have to end here because we are quite way off the time. So thank you very much. Sorry that I have to rush through the case presenters because of time constraint. Again, I would like to thank all the speakers, all the case presenters for your hard work in helping us to make this webinar a success. And I'll pass back to the organizer. Vijay, do you have any last comment?
No. I would like to thank all the speakers and the faculty for this engaging and enriching program. Thank you.
Thank you.
Okay.
Thank you, everybody.
So pass back to Dr.
you,
Vishal for Dr. Vishal for his summary and last comments.
Thank you, Chi. Thank you,
Dr.
Vijay.
Vishal. Yeah, Vishal, do you have anything?
It has been a wonderful program, and 2 hours on a topic like early onset and congenital scoliosis may not have done justice unless we had speakers like what we heard this afternoon. Early onset scoliosis has been an enigma and challenges, and I think these challenges can be brought down if we only know the natural history, which was brought up very beautifully, enlightening that not all of them progress. In fact, 50% of them may not require any attention, and following them up may let us understand which are the cases which actually will require surgery. Casting and bracing as a management in early onset scoliosis has been revamped and has a definite role to play, particularly in very, very young kids and in cases where they are waiting surgery or are not fit for surgery at this time. And in many of these cases, bracing and casting can really prove to be a miracle. Magnetic rods, they are really a boon for patients who require early onset scoliosis surgery because they mimic growth and they can prevent or delay the definitive fusion surgery in these patients, giving them a better trunk balance at a later date. Congenital scoliosis, we heard Prof. Kwan speaking about all the 6 options in great detail, right from epiphyseal disease to corrections to osteotomies and a combination of various type of surgical options in congenital scoliosis management, which will come very handy in planning surgery for these patients. Halo gravity, halo pelvic, and various forms of traction and their role in severe rigid scoliosis was very beautifully explained by Dr. Rajashekharan, and I'm sure we all seem convinced that in most cases of severe rigid scoliosis, at least the magnitude of surgery, the complexity of the surgery can be brought down by use of in-housed halo gravity traction in such patients. Neuromuscular and syndromic scoliosis, they pose a challenge like they have always done, and various surgical options have been described in detail as Prof. Yu does mention. Also, neurophysiological interventions were spoken about them in detail. We heard all these principles discussed by speakers being practically implied in the cases discussed with Dr. Chris, Dr. Neeraj, and Dr. Lim from Singapore. I take this opportunity to thank all the faculty members who spared their time on this Sunday afternoon to bring forward an enriching discussion on this enigmatic topic on early onset congenital and neuromuscular scoliosis. Thank you all for being around. I also thank Kayleen, Jennifer, and the whole secretariat for putting up the best foot forward to make this program a great success. OrthoTV has always been the backbone to relay the program to wide across the nation and also in the wide parts of the continent. I take this opportunity to thank Medtronic for supporting this webinar program, and I take this opportunity to invite you all for the 4th webinar in the series of spinal deformity, which is on surgical techniques in scoliosis and kyphosis surgery. We saw the first webinar on scoliosis starting in January 2022, and then we discussed 2 webinars on adolescent idiopathic scoliosis. The basic principles and details were discussed in the first 2 webinars. Today's webinar being on early onset congenital neuromuscular scoliosis on basic principles. The 4th webinar will see a culmination of all the surgical techniques, right from choosing the levels, how to do reduction maneuvers, direct vertebral rotation, osteotomies, and various other surgical nuances that a surgeon would want to learn from about how to do a surgery in scoliosis and kyphosis. So please block your dates. Join us for another program that is going to come forward, which is in 27th November, is the last Sunday of the November month. Thank you all. Thank you again for being with us.